Well, hello everyone. I'm Jeannine Forrest and I'll be hosting today's Dementia Unplugged. We'll be talking about triggers for agitation and aggression and other unmet needs. So welcome to all of you who have the time and the energy, and so glad you can join us. Before we start the discussion, I do want you to hear a word from the president of Dementia Unplugged, Kevin Jameson.
Welcome. Please listen to this important message from the Dementia Society of America. All content, including any potential medical information, is provided as an informational resource only and is not to be used or relied on for any diagnostic or treatment process. It should not be used as a substitute for professional diagnosis, care, and treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. The opinions expressed and the content shared by Dr. Forrest are not necessarily the opinions and content of the Dementia Society of America. Thank you.
I'd like to start out by just sort of sharing the format if you're new to this webcast. Basically, I give an overview and add some thoughts and ideas regarding the topic for about 30 minutes, and then we open it up for Q&A, for which you can type in your questions and I'll answer those live. The question part will not be recorded in order to maintain your privacy. I also like to start out by just sort of making sure that we are all on the same page in terms of nomenclature or what the word dementia means. The word dementia is really an umbrella term, like the word cancer. There are many, many different types of cancers: breast cancer, lung cancer, prostate. Similarly, that also applies to dementia. There are over, the newest research indicates that there are over 400 different reasons for a dementia to occur. Dementia just means that there are at least 2 or more cognitive functions that are no longer working properly, and there's progressive decline. So you're probably most familiar with the Alzheimer's related disease. And then there's Lewy body, frontal temporal, many, many different reasons to cause a dementia. Regardless, when we're talking about the current topic, aggression and agitation and other unmet needs, this topic applies to all, regardless of the type. So I want to start out by saying, from my own clinical practice, my own personal experience with family members with different types of dementias, that not everyone with dementia becomes aggressive or agitated. Has that been your experience? If that was the case, my goodness, could you imagine if I walked into a memory care facility and everyone there was experiencing some form of distress? That would just be almost unimaginable. But the reality is, aggression and agitation do happen, but not to everyone. So what makes the difference? What makes the difference? So I want to share with you some of the characteristics of people with whatever type of dementia who do not exhibit aggression and agitation. And what I mean by aggression and agitation, I think we might have to make that more clear. I've seen this run the entire gamut, from people who just yell or moan or become physically combative, crying, pacing uncontrollably. You can certainly add, hitting, spitting, cursing. That's the extreme. But what are the characteristics of people with dementia who do not exhibit this aggression and agitation? And this does happen. I've had this private practice now for over 6 years, and I've been in situations for the entire duration of one's dementia journey. They've not experienced one episode of this. So really, what makes the difference? So I want to share some of these characteristics. The person with the dementia feels loved. Now, I want to emphasize the feels loved. Someone can be loved, certainly, but do they feel loved? They feel safe. Certainly, they may be in a place that, prevents falls, and they may be secure, but does the person feel safe? This really adds a whole other sort of aspect to when we're looking at triggers for agitation and distress. I'm going to go through the others, and I think you might be following my lead here. They feel that someone acknowledges their distress. They feel socially connected and engaged in meaningful activities. The person is physically comfortable, meaning there's no underlying discomfort or physical pain. They're not overstimulated, so they're not going from one activity to the next with no break in between. The person is well rested, well hydrated and nourished, and there's an absence of infection. So I just want you to keep an open mind here that people with various types of dementias really move from sort of a cognitive place, meaning that people in general have a tendency, we communicate and we live on this hypercognitive playing field. But when that is no longer the case, people move much more into an emotional realm. And so this is the area that I want you to think more deeply about when we're talking about triggers for agitation and distress and aggression. And I want you to insert the word unmet needs. So whenever someone is really exhibiting, and I'm going to put this word in quote, behaviors that are distressing, I want you to insert the word unmet need to start. All right, let's continue. I have found in my clinical practice and working with various care communities that there can be a tendency to put sort of distressed behaviors into a black box, meaning everything is related to the dementia. Oh, they're just moaning and groaning and crying. Oh, that's just the dementia. Oh, they're upset. Oh, it's just the dementia that's taking place or getting worse. Oh my goodness, they're resisting their showers or not wanting to get dressed. Oh my goodness, it must be the dementia. I want to really tease that apart because I think there's a tendency to put everything in this black box called dementia without taking the time and energy to investigate. Is there an underlying cause? Is there an underlying trigger? Because without that, then we kind of wash our hands and say, well, there's nothing I can do about it. When in fact, my reason for giving this talk is to say there is hope. There are many ways that we can go onward and try to investigate the reasons behind these behaviors. And once we can identify those triggers, the hope is that we can address them and help to diminish them. So in fact, this distressed behavior does no longer occur. I'm hoping that makes some sense so far. I did give this similar, excuse me, talk last year a little bit on sort of distressed behaviors, but I'm hoping to kind of fine tune it a little bit. But if some of you have listened in the past, what I have said is that the triggers for distress can really come out of 4 different categories or buckets. And those are the caregiver approach, physical distress, some form of physical distress, something happening within the environment, or an underlying mental illness that's been, maybe not well managed or could be managed differently. And that often comes in the form of severe depression or schizophrenia. So there's an underlying psychiatric illness in addition to the dementia, which really complicates all of this. But what I find in my practice, and this is how I spend a lot of time, educating and coaching family members, it's often in the way we interact. And through no fault of our own. I would like to say that none of this is intuitive. My guess is that not many, went to school to learn how to interact and relate and communicate with people with dementia. That's just not, that's not in our school system. But now we are catapulted into a situation in which we have to learn how to navigate and communicate on a whole different level with a brain of someone else that's changing. So the way I want you to look at this is think about your own situation. And if you've joined us because you're concerned about a loved one or someone that you care for professionally that is distressed, I want you to start going through these 4 different categories or buckets. And I'm going to dive into those in more detail now. With a background understanding that we're working with someone else's, and I'll put it, brain that's becoming more at risk. And this is unfortunately the progressive nature of various dementias. On the screen, if you're joining me by, online, you're going to see a picture of a brain, which gives you some insight. On the right side, you'll see brain tissue that's healthy and dense, and it looks, I'll try to describe it, almost like a cauliflower, sort of a subsection of the brain. On the left, unfortunately, what you're seeing is a person with advanced Alzheimer's related dementia. And you're going to see incredible shrinkage. It looks like holes within the brain. And the reason I'm sharing this is because this is what's taking place over time. And we don't see this. We see someone with an intact skull, cranium, and we don't have X-ray vision. And so that way, we're not always cognizant of the fact that these brain changes are taking place. And so if we could, in some way, when you're working or caring for a loved one with dementia, keep in mind that they have no control of the fact that there are less and less cells that are communicating within the brain. The neurons are not functioning as well as you and I. And so we have to take that into consideration. People with dementia who are comfortable and who feel comfortable. Do not moan, scream, kick, hit, fight, right? It relates to an unmet need. And so what's happening within the brain to make someone more more fragile in a way that makes this even more complicated. There are changes in visual spatial abilities. So if I have dementia and I'm looking in a room and I may be seeing a vacuum, this happened in the hallway, and thinking that it's a little girl, wondering, why she's staring at me. If I'm unable to navigate the depth of a stair, or if I'm looking at shadows on a wall in the evening and thinking there may be, someone else in the room, this really adds to a distress. The impaired short-term memory also plays a role. So if I'm not recognizing people in my life who are coming and going, I can still recall this moment in my life when my mom looked at me and said, "I'm in a house of strangers." How can you trust someone to help you with intimate tasks such as bathing and dressing if you think the person who is trying to help you is a stranger? There's a decline in problem-solving abilities, and that also adds to this complexity. So for those of you who are experiencing a loved one or someone with dementia who is distressed and aggravated, know that this is not easy. That's why we're in this together. That's why I'm hoping we learn from our shared experience and how to improve the quality of life. And instead of trying to reinvent the wheel, let me share some more ideas. So I'm going to give you sort of a checklist for what, excuse me, for what I call caregiver-induced distress. Now, we know that this is something you're not doing intentionally, but one of the things that's helpful is when I work with family members is we sometimes just sort of work on autopilot, do we not? And we can't always see our own ways that we behave and interact with others until someone else points it out. So I want you to kind of, take a step back and think about the last time someone was distressed. And let's see if we play a role in any of this. And I do this myself when I'm working, when I'm called in to figure out why someone is agitated. These are sort of the mental checklists that I go through. Number one, do I come into this situation angry, frustrated, exhausted? That can more easily be absorbed by the person with dementia. Remember, people act more on an emotional level. And so hasn't been your experience that someone, let's say a loved one of your own walks into the room and without saying a word, they're upset or angry. And you want to have nothing to do with that person. Well, the same applies here. You might be having a rough day. You're trying to take care of your own kids, and now you visit your parent with some form of dementia, and you've gone through heavy track, and you walk in and you're frustrated, and bang. Just that look alone can really start to set someone off. Other things. Am I quizzing or trying to argue or convince someone to do something, when in fact that part of the brain that recognize or has self-knowledge or insight is really starting to dissipate? And am I spending more my time arguing with someone and trying to convince them, and it escalates into an angry sort of interchange. That certainly can cause more aggression. Am I rushed? Am I trying to get things done, get someone dressed quickly? Do I spend most of my time telling someone, no, don't do that, stop, don't? Imagine if that was you and you had a majority of your day with someone telling you what, just the word stop, don't, no. I don't know. I would get pretty upset and frustrated myself if those were the words that I heard the most frequently. Are you blaming or scolding? Are you trying to put the task before the person? Meaning, oh my goodness, I need to have, this person fed and dressed and ready by X amount of time, versus looking at the fact that maybe, they didn't sleep well the night before. Am I using put downs? Here's one. Unfortunately, and I'm hoping this may be more in the past, but I still hear people who need assistance eating referred to as feeders. Imagine if you were that person listening to that, or even the words bib or diapers. Oh, let's change your diaper now, mom. Wow. Those words mean something, and they still can mean something, and they can be incredibly infantilizing or demeaning. So we have to watch the language we use. Am I talking too fast? Am I expecting too much? I have a picture of someone with a cast on their leg. Imagine if I asked that person, come on, let's go run a mile. They would say, what kind of healthcare provider are you? Can't you see I have a broken leg? Well, the person with the dementia may not be saying this, but sometimes we're asking someone to do something in a way that doesn't reflect the fact that their brain is changing and declining. And so sometimes we expect too much, especially when we talk too fast and ask too many questions at once. And so my hope is not to overwhelm you, but to really sort of have you start to take this apart and not put everything into the black box of dementia, but really start to recognize, maybe I do need to speak more slowly. Maybe I should not start, every answer with no or don't or you can't. Other triggers that may cause distress. Is the person over fatigued? I see this when, people go from activity to activity to activity to activity, and maybe a break for lunch and then more activities, and the brain is overstimulated. Pain. Poorly controlled or undetected pain is a major, major trigger for aggression and agitation. This was the focus of all of my doctoral work in the 90s. And so, and it's still not well recognized. Someone's overscheduled. Here's one, sitting too long in the same position. Imagine if you were in the same wheelchair for 5, 6, 8 hours at a time, maybe up once to be toileted, and then told to sit down anytime you try to stretch your legs and stand up to really ease the discomfort of sitting in the same place for such a long time. And this occurs, and unfortunately this still occurs. And so this is a hidden factor. Look at how much time someone stays in the same position. Imagine yourself. And if you have any history of arthritis or back pain or sciatica, that only exacerbates this issue. Other unmet needs, hunger, thirst, are you constipated? An infection. This often blooms into what we call a delirium or acute confusion. And so just a quick aside, if someone has sort of a baseline behavior, within their dementia. And then it seems almost suddenly or out of the blue, there's an exacerbation. There is an inability to pay attention. There may be hallucinations. There's much more of an exaggerated response than clearly did not occur the day before. This often indicates a urinary tract infection or bladder infection or pneumonia. So that's separate and that needs to be handled medically. Okay, other triggers to consider. Is someone bored? Too much noise? Is it overcrowded? Too much clutter? Too hot? Too cold? Yes, this is a long laundry list, but this is exactly what I do when I go in and do an evaluation. I'm looking, and this is, part of the environment. If there's just too much noise, is it too much light? So is the TV on too loud? Is the TV on in the background that shows war and horrible sort of violent acts? This can cause an agitation. Give you an example. For example, someone who becomes resistant during showers. And this kind of pulls together some of these categories all at once. So a home health aide or even a family member wants to give someone with dementia, usually in the middle to later stages, a shower. And they assume day to day that the person remembers who they are, when in fact the brain is changing. So imagine if I knocked on your door this morning, you don't really know me, and I say, okay, Mary, come on, it's time to take your shower. Let's take your clothes off. And I start undressing you. Now, I would hope that your response would be to say, no, get out of here. I don't know you. Slam the door, say, I'm going to call the police. Want to punch me in the nose, right? That makes total sense in someone with dementia who does not recognize you. But how many times does that happen where people don't take the time to reintroduce oneself, to establish a relationship in trust? And that can happen over, 10, 15 minutes instead of rushing into the task. It could be someone doesn't recognize what a shower head is for. And so it can be a scary place. Someone could be unclothed, it's cold. That's why I always start with showering at the feet and moving upward. Washing the hair and the face last because it's least distressing. So that just gives you sort of one little snippet into how to use this practically. A couple other thoughts. The underlying either poorly managed mental illness that comes in the form of severe depression and a history of schizophrenia. So this is when people with this type of underlying background really do need to be managed with different types of medications that may include antidepressants and their antipsychotics. In general, the golden rule is that antipsychotics in general should not be the first line of defense for people who show any form of aggression or resistance or agitation. Because in fact, if you eliminate the underlying cause, let's say I am always saying no, 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 and I learn how to change my language, and that person becomes more calm and feels more loved and relaxed, there's no need at all for the antipsychotic. Same thing when pain comes into play. If scheduled Tylenol will do the trick and make someone with arthritis more comfortable so that when I do help to help someone get undressed and manipulate that shoulder or leg and don't cause pain. That takes care of the agitation and distress much more than giving, let's say, an Ativan or a Seroquel. So a lot to think about. All right, so what helps? I hope you're starting to distill from these checklists of what perhaps we can do differently. But some other thoughts here. When someone becomes aggressive or distressed or agitated, stop what you're doing. Don't continue. Step back. Take a deep breath. If it's not critical, leave the room. Try again with a new approach. I want you to review that list of triggers. Review the characteristics of individuals who do not experience aggression. Here's one. Keep yourself rested and ask for help. This is not easy. We're in this together. Ask to be educated. Don't try to do this alone. Journal your own experience. Look to see if there is an episode of distress. What may have happened prior? Approach from a position of love and curiosity. Not always easy, but if we can get to a place that we're looking at these, quote, behaviors, and I really don't like to use that word because we all behave all the time. It just sounds so foreign. You know, all behaviors have meaning. And so if you're using behaviors with distressed sort of actions, please use the word, some form of distress, because we all behave all the time. From love and curiosity. I wonder what is prompting this response. And a strategy that works, and perhaps I may even do another program on this, is the use of looking at improv. And it looks like something like this. You use the words yes and. So I had a client who loved to microwave her own coffee, but would sometimes leave it in for 10 minutes and explode the entire cup. And the husband just became incredibly frustrated. And as soon as she got up to do this was something she enjoyed doing, he would say, "No, stop, get out of there," starting sort of this restless, agitated reaction. And so when she got up, instead of saying, "No, don't stop," it was, "Yes, and then he would follow it with something, and look at this beautiful mug and the picture on it, and wouldn't coffee cake be wonderful with that?" And he would use that type of language to distract her from punching in the 10-minute button. So this takes a lot of, some practice and creativity, but it can give you a clue in how to sort of navigate differently. So I do kind of end this discussion by hoping this one, quote helps. So you cannot control the wind, meaning, you're doing your best, and these distressed reactions can come across, and wow, you may not understand why they're happening in the first place, but you can learn to adjust your sails. So a lot of it, and the way this agitation and aggression cannot be escalated, is for you to keep sort of a calm demeanor the best way you can. People absorb how you respond. So if you can respond in a quiet, calm manner, no matter how agitated or distressed they become, it really does help to de-escalate the situation. Not easy, but it can be doable. So we're all learning to care before we find the cure or the cures for the different types of dementias. If any of you would like a one-to-one consultation within your own particular situation, I have my own private practice. It comes from my last name, called Through the Forest, but I am sort of rebranding. And so the new service is called Dementia Coach on Call. Dementia Coach on Call. And the website is dementiacoachoncall.com. The Dementia Coach on Call is all one word, no hyphen in that, .com. And my number is 773-704-1834. I would love for you to take a look at the new website. This is sort of a work in progress for me, and I'd love any feedback. I want to thank you on behalf of the Dementia Society of America. This is a wonderful, wonderful organization with it's chock full of information and education for caregivers, and very useful. I would encourage you to donate as well to this amazing cause. So I will be ending the recording with the next slide. So while I'm doing that, I want you to start thinking of questions so we can answer them. Thank you so much.